Good morning, everybody. This is a topic that has been widely spoken about yesterday, debated, contested, and probably still remains as intriguing as it was till it was spoken of. So, transplanting elderly kidneys into young or old recipients, pros and cons. I myself believe very strongly that instead of the pros and cons of this elderly kidneys, it's basically about the abilities of the managing team, the systems which actually decide on the subsequent outcomes of a elderly or a young transplant in any recipient. As we have seen, prehabilitation, and equally important is the post transplant management. So whatever is available to us, depending on that, I have some analysis of some studies that are available in the literature on this topic, which I have analyzed and put forth for all of us to deliberate upon. So what is an elderly? There's a contest about what is elderly. The definition of an elderly person is somewhat arbitrary and usually refers to the age when one receives pension. Why marginalize the elderly? As Madam also said yesterday, Dr. Shalini. So due to this lack of consensus in the age cutoff, present studies involving elderly patients suffer from a lack of uniformity and generalizability. Transplant is a compromise between more time on dialysis and the increasing likelihood of cardiovascular events versus transplant organs of marginal quality. When it comes to weighing the options between the two, transplant should be the choice. Now, what are the challenges that we faced in these organs, the elderly organs? The associated pathology, because the kidney has traversed almost 5 or 6 decades of function. The vascular problems that are encountered more so for the surgeon concerned. The organ loss, the functional loss of the organs and also in the corresponding organs in the body, and retrieval injuries, which are very common because of the frailty component of these organs. So these are the issues mainly which plague the kidneys from elderly donors. They also, moreover, the organs also lose the ability to undergo compensatory hypertrophy, and many of them are more susceptible to nephrotoxicity, hypertension, and immune mediated changes. So what are the implications? The increased mortality due to cardiovascular events during and after transplantation or even prior to transplantation is observed more commonly in these patients. Atherosclerosis accelerated is usually an accelerated process in the ESRD patients. So the internal iliac arteries, the surgeons who are more prone to using internal iliac artery for anastomosis to the renal artery, they find the internal iliac artery to be unsuitable for this anastomosis. And external iliac artery also we are unable to clamp because of the various segments of the external iliac artery which have strong and very hard plaques, which you cannot actually clamp in the Satinsky clamp. So presence of pre-existing aortic aneurysms is another thing which is observed in the elderly donors or in the recipients as well. These surprises thus may necessitate the change of anatomic region for transplantation, availability of prosthetic vessels and their replacement, and arterectomy, and so it needs a surgical expertise to deal with these surprises that may be thrown at him during the surgical procedure. In grafts, the renal artery anomalies may require thrombo and arterectomies, saphenous vein interposition, and the surgeon expert, as I said, has to be equally competent. Other management issues that have to be strongly considered are frailty, the cognitive impairment, wherein the risks of medicine compliance also weighs very heavily. The patient may not be able to remember the medicines that he has to take. He needs a strong social and a familial support. The immunological and metabolic changes in aging predispose these patients to infections and malignancies, which are also superadded because of the added immunosuppression. Managing the immunosuppression is thus a fine line between adequate and over immunosuppression. Plus, this body has already lost the flexibility to counterbalance the metabolism of associated drugs, and that's why the chance of inter-drug complications is also very high. Now, this is a paper wherein there was a proportion of donors more than 70 years was about 10%, which says that the proportion of donors about 15 years back was 10%. Now it is almost 22%, and 85% of these are more than 75 years of age. The mortality decreases compared to remaining on hemodialysis, that is if you transplant these patients, so the mortality is observed to have come down. Plus the death censored graft survival at 1 and 5 years is 92% and 81.5%. Limitation is that 41% of these patients have delayed graft functions. However, there is no primary non-function owing to the elderly graft. And dual and single kidney transplants have similar 5-year graft survival, that is 84%. So what is the scenario today? The overall deceased and living donor scenario, adjusted hazard for graft failure has steadily decreased from 0.89 in a period of 2000 to 2004 to 0.46 during the period of 2014 to 2017. The median survival for deceased donor kidney transplant has increased from 8.2 years up to 1999 to 11.7 years in the most recent era. Living kidney donor transplant median survival has increased from 12.1 years to 19.2 years in the same corresponding era. So this is suggestive of continuous improvement in long-term outcomes, especially among the higher risk subgroups, suggesting a narrowing in the gap for those disadvantaged after transplantation. Now, what are the basic functions of kidneys? These need not be elaborated upon, but they are multifold, right from purification of blood, blood pressure maintenance, salt and water balance, acid-base balance, bone and minerals balance. So it is overwhelming. So the changes that occur in elderly kidneys are structural and functional. The mass goes down, usually from 400 at the peak time during adulthood to about 300 grams. Glomeruli, the number of functioning glomeruli is observed to almost go down by about 40%. And the renal plasma flow also decreases by 10% with every passing decade of life. Senescence is one thing which is a gradual progressive decline in the cellular function and structural changes. Age-related diseases, that is diabetes, mellitus and hypertension, are also found to be coexisting in such patients. They accelerate the process of senescence. The functional changes is a decrease in GFR, linear decline after the age of 30 years. Average is about 7 ml per minute per decade, and by age 90 it should be almost a 46% loss in the GFR, baseline GFR. Changes in permeability of the capillary walls, changes in tubular reabsorption and secretion, changes in concentrating ability of the kidney, and decrease in production of hormones and bioactive molecules. Plus the podocytes injury, glomerular obsolescence, reduction in GFR and albumin permeability overall reduces the functionality of the older grafts. This is again a study which substantiates that the globally sclerotic glomeruli, that is collapsed glomerular tufts, are more prevalent to less than 18% below the age of 30 years to almost about 82% in patients who are 70 years and above. Clinical significance, however, all these studies say that the age-related functional decline has little effect on the life expectancy alone, and alone should not exclude donation from these donors. It should be a comprehensive picture that has to be considered while taking these grafts. Now, what are the actual facts? The 30 to 60% kidneys received worldwide are from extended criteria donors, and age is just one of the factors, but it is definitely a significant one. However, the kidney discard rates still remain very high, and for grafts which are more than 80 years, the discard rate is almost about 48.2%. So main issues in these elderly grafts is that there is a high incidence of exposure to risks which can cause or predispose to acute kidney injury. Recovery from the acute kidney injury is delayed or incomplete in such grafts. Dehydration due to reduced thirst and appetite. The older age patients have this repeated or a very high frequency of dehydration episodes. Plus, because of the associated illnesses, they are already on various drugs, so which is called as polypharmacy. The drug interactions also have to be kept in mind. Risk is increased by frequent exposure and reduced handling capacity of the kidney, as I have mentioned about the functional loss. And recipients of age 65 years and older have about 21% improvement in 5-year graft survival, as we are seeing progressive improvement in the peri-transplantation management of the patients. So the predictive half-life for those transplanted up to 2017, as I said, was 11.7 years earlier, and 43% increase has happened in the last 20 years. Improvement is more pronounced in older than in the younger recipients. This study mentions with the 70 the new 60. So this is a very encouraging study that says that the 5-year graft survival improved in all donor age groups. 5-year death censored graft survival of kidneys from more than 70 years improved to the level of 60 to 69 in 2016. In 2018, 25% of the kidneys in the Eurotransplant region came from donors more than 65 years, and recipients between 45 to 64 show best 5 years death censored graft survivals for kidneys from donors more than 60 years. Younger recipients show significantly reduced survivals. So now, why are we in a position to offer better survival, that is a 5 years death censored graft survival? It's because of the improved post-transplant surveillance, close supervision of individualized immunosuppressive drug levels, regular screening of donor-specific antibodies, effective antiviral prophylaxis, better prognosis and treatment of concomitant cardiovascular and renal risk factors, advances in peri-transplant alloantibody detection, and improve kidney storage and preservation facilities. Some centers still propagate the use of dual kidney transplantation. So there was a study which says, is it worth it? So we have to consider the surgical aspects of a dual kidney transplant. There's an increased incidence of vascular calcifications in the elderly kidneys, increased intraparenchymal vascular resistance. Both the above lead to increased risks of vascular thrombosis. So both these issues put the number of grafts to be tackled also increases, and that's why the complication rate also increases here for post-operative consideration. Long segments of the arteries and veins are not available for anastomosis. We have to find wherever the anastomosis site is available, we have to anastomose the renal vessels. There are no differences in complications with uni or bilateral placements. And complications, there is a higher frequency of graft thrombosis of 13.6% versus 4.3% for single kidney transplantation. So higher risk of acute coronary syndrome is also observed, 12.3% versus 0% for a single kidney transplant. The operative time also increases, blood loss also increases. So this study mainly proposes that single kidney transplant is equally effective as dual kidney transplant, and dual kidney transplant offers no extra benefits. This is another study which is Asian. It has the number of patients, although is very low. Extremely marginal donors, age more than 70. The eGFR was less than 30 ml per minute. Serum creatinine to more than 3 milligram per deciliter. Single kidneys of this donor refused by all other centers. Death censored graft survival at 3 years was 100%. 1 year graft failure after 3 years due to diabetic nephropathy. DGF was 20%, and the nadir serum creatinine and time to nadir was comparable in both single and standard criteria and superior and extended criteria donors. So this probably still leaves it open whether we should do a dual kidney or a single kidney transplantation. This was another study from Spain, which had almost 1,084 kidney recipients from the age group of 60 to 79%. 128 of these donors were more than 80 years, 67 of these received kidney transplant from both dual kidney transplantation, and 62 were between 60 to 79 years. 2 were more than 80 years. Dual use was unjustified. The conclusion they drew was the dual kidney transplant was unjustified, and to have extra nephrons in a person without life expectancy is no longer than the graft survival. One kidney is enough to give survival benefit. Practice of dual kidney transplant they have literally abandoned. Back home, we have very little data available with us. At ZTCC Nagpur, we had till now about 174 donors in 11 years, of which 33 were more than 60 years of age. Of these 60 years, 18.96, that was about percentage-wise, it was about 19% were elderly grafts. So these are this is a profile wherein we observe that about only 15 of the 66 were elderly recipients from elderly kidneys. So the elderly kidneys were mainly transplanted. About 78% were transplanted to younger recipients, and only 22% were transplanted to the parallel age group recipients. So if we see the total number of donor profile and the total recipients profile, we'll see that as India at the moment is a country which is supposed to have a maximum number of youth, so the maximum population in the youth age group. However, this is going to go otherwise, as longevity increases to extremes, the peaks of both the curves will certainly shift more to the right with time, and we'll have more number of elderly donors as well as more number of elderly recipients. We have to keep this in mind and thus encourage transplantation and acceptance of elderly donor grafts. In my own practice, I have had a 79-year-old recipient who had received a kidney of 65 years donor. He is alive till more than 5 years, is 84 years now. And the oldest arteriovenous fistula that I have done in practice has been a 95-year-old gentleman who's on dialysis. This is I had emphasized on this donor yesterday, a patient of a live donor transplantation, 65-year-old donor, a female. We had harvested the right kidney with a IVC cuff, and during the harvesting procedure, it was not evident. However, on the bench preparation, we found the lumen to be totally obliterated. As you can see, just because the IVC cuffs are there, it appeared to have an open lumen, but down inside it was a total obliteration of the lumen. This is the side view and this is the end-on view of the same. So we had to interpose a saphenous vein graft at a available length of the vein, an alternative vein, not the main renal vein. And this is the picture wherein the saphenous vein graft has been interposed and anastomosed to the extrailiac vein. And this is the post-operative, the post-clamp release video. The kidney perfusion is good, the kidney is pink, and it's almost about 5 months now. The patient is doing well. This is another elderly recipient who was a 72-year-old female. She received a donor with a renal pelvic calculus from a 65-year-old donor. The renal pelvic calculus was removed and the kidney was transplanted. The patient is almost about 2.5 years post transplantation and she is doing well even today. Thank you.